Okay, so welcome everyone to the first session, Host Pathogen Interactions. And the first speaker, so we're a little bit behind, so every talk will be half an hour, and after 25 minutes we will try to have some discussion and Q&A session. So the first speaker is Professor Dani Cohen, who will be talking about challenges related to Shigella vaccine.
Thank you very much, and I will try in the next minutes to share with you from our experience of a couple of decades on the development of Shigella vaccines. Shigella is a leading cause of moderate to severe diarrhea and of dysentery globally. And shigellosis is common worldwide, but it's hyper-endemic in low and middle-income countries, with almost 200 million cases annually, and also causing death of more than 60,000 children under 5 in LMICs. In addition to morbidity and mortality, Shigella is associated with malnutrition and linear growth faltering in LMICs. Shigellosis is also common in industrialized countries with almost 2 million cases annually. And of much concern is the emerging antimicrobial resistance of Shigella isolates. There are 4 Shigella species or serogroups: Soniae, Flexneri, Dysenteria, and Shigella boydii. And Shigella soniae is the predominant species in industrialized countries, while Flexneri is the leading Shigella species in LMICs. As a virulence mechanism, Shigella is an invasive organism of the colonic epithelium, causing destruction of the epithelium of the mucosa through a type 3 secretory system encoded by genes on a large 140 megadalton plasmid. What is a characteristic of Shigella is the very low infectious dose that enables the transmission of the organism by all means, person to person, fomite-borne, foodborne, waterborne, and also fly-borne transmission. And despite this burden of disease, both in developing countries and developed countries, there is no licensed vaccine against shigellosis available to date. Shigellosis is highly endemic in Israel, despite having Israel being a high-income country with a mean incidence rate of about 1 culture-proven cases per 1,000, which is about 10 to 20 times higher incidence than that in the United States or in other industrialized countries. And the children age 1 to 4, and soldiers serving under field conditions are at highest risk to have shigellosis. To date, Shigella soniae is the predominant Shigella serogroup, species being responsible for more than 90% of cases of shigellosis. What we know from seroepidemiological studies that we carried out is that natural Shigella infection confers protection. Protection is about 70%, and it is serotype specific, indicating that the O-specific antigen of the organs of Shigella is the protective antigen. And the protection is of short duration, natural acquired protection, about 2 years or less. It is desired that a vaccine against shigellosis should confer protection at least similar to that induced by natural infection. And the targets are multivalent vaccines, because in order to cover all the common Shigella serotypes and serogroups worldwide, but this can be actually achieved after demonstrating the proof of concept of a monovalent construct that can induce be immunogenic and also protective. The Shigella vaccine development strategy actually includes 2 main approaches: the development of the oral live attenuated vaccines or parenteral subunit vaccines. And the oral live attenuated vaccines against shigellosis dominated the scene of vaccine development since the 70s, I would say, until the 90s. And they included first, in the first period, the 1970s to 80s, the oral attenuated strains obtained by the classical serial passage in vitro of virulent organisms that lost virulence. And this was actually continued, it was followed by the development of oral live attenuated mutants rationally obtained by recombinant DNA technology. And this was actually developed since the 80s. And this was actually a logic and a good and well-accepted approach in Shigella vaccine development, trying actually to mimic natural infection and to by the route of infection, and also trying to induce mucosal immunity by means of IgA at the level of the colon mucosa. However, and unfortunately, the live attenuated vaccines had two important, I would say, two great drawbacks. First of all, there was a narrow window between immunogenicity and reactogenicity, especially in the new generation of the recombinant vaccines. And most importantly, these vaccines, actually, they proved to be less immunogenic when administered to infants, children, or adults living in less developed countries than when used in industrialized countries. And this was an important drawback because these vaccines, the target population, the primary population, are children in developing countries. And there is a poorly understood intestinal barrier to successful immunization with live attenuated vaccines in LMICs. And we have also the example of the live attenuated rotavirus vaccines, where the efficacy of these vaccines is about 50% in Africa as compared to 90% in industrialized countries, and other the much higher doses or more doses of the oral polio vaccine given in developing countries in order to get protection, and other examples with live attenuated vaccines. In the 90s, the late 80s and 90s, in parallel to being actually involved in the evaluation of oral live attenuated vaccines, we carried seroepidemiological studies and studied a lot the natural Shigella infection. And we conducted case control studies and prospective studies among Israeli recruits serving under field conditions where the disease, Shigellosis, was common, and they were actually heavily exposed to Shigella during their training in the field. We found out that serum IgG anti-Shigella LPS antibodies were strongly associated with protection against a disease caused by the homologous strain of Shigella. And these observations and these data were critical and actually helped to the development of the first generation of the subunit vaccines, actually the conjugate vaccines. And this was a breakthrough in the concept of a vaccine against Shigellosis, instead actually of the live attenuated vaccine approach. And this has been done by John Robbins and Rachel Schneersohn at NIH based on these observations and data that we provided from the field. And these vaccines, actually the first generation of the O-specific polysaccharides covalently bound to a carrier protein. This is the classical approach for a conjugate vaccine. The aim was to have the capability to induce a high level of serum IgG antibodies, like we actually observed in the field, and when these vaccines were injected intramuscularly. And actually, this was the approach of the conjugate vaccine, and the experience following the outstanding results of the first conjugates, the Haemophilus influenza type B conjugate that that Robbins and Schneersohn developed, and these vaccines were a revolution in preventing, I would say, millions of cases along the years of Haemophilus meningitis in young kids. So this was the approach, actually assuming that when you have high levels of IgG antibodies in circulation, part of these antibodies will leak to the local level, will transudate, and there at the local level they will actually fight the invading Shigella organisms, and probably in presence of complement or other mechanisms, they actually will protect against local infection and, of course, systemic one. And these were the results of the phase 2 study that we carried out in Israel with this first generation of conjugates, in this case, the Shigella sonnei, OPS covalently bound to recombinant exoprotein A of Pseudomonas aeruginosa. This was the carrier protein, and we found out that just one injection of this conjugate induced high levels of IgG and IgE antibodies that persisted at these levels for more than 2 years, as compared actually to nothing happening in terms of the immune response against Shigella LPS, the same Shigella sonnei LPS in vaccinees who received the control vaccines, the hepatitis B vaccine, documenting actually that this response was entirely related to the vaccine. Based on these immunogenicity data and on very good profile of the safety of these vaccines, we went to an efficacy study, a double-blind vaccine-controlled randomized efficacy trial among soldiers, again in these units highly exposed to Shigella, and we found out that the vaccine actually conferred 74% protective efficacy. Actually, we found out that vaccinees had a much lower, much lower attack rate as compared to placebo recipients, and this difference actually in the attack rate yielded a 74% protective efficacy. And again, the vaccine, and this was very important, the vaccine actually induced a much stronger, much more vigorous immune response than natural infection, about 22-fold increase in IgG titers in vaccinees as compared to what natural infection induced, actually showing that the vaccine can do better than natural infection. And we also found out that these are important data that cases of the volunteers who developed shigellosis had much lower GMT of antibodies, much lower than vaccinees who did not, than volunteers who did not develop shigellosis. And this was, again, an indication that protection conferred by the conjugate, this conjugate against Shigella sonnei, was mediated by serum antibodies, IgG antibodies against the LPS. And then, based on the success, I would say the good results in terms of efficacy and immunogenicity of the sonnei conjugate in young adults, clinical trial started in an efficacy study in children aged 1 to 4. These followed actually a series of age-descending phase 2 studies in children, and actually the design of this study was a vaccine-controlled study in which Shigella sonnei conjugate was actually the volunteers who received, or children who received either the sonnei conjugate or the Flexneri 2A conjugate. Each of these vaccines was the control for the other, because there is no cross-reactivity or cross-protection between these strains. And what happened is that the vaccine was conferred 70% protection, but only in children aged 3 to 4, without actually conferring protection in children younger than 3 years. This was the protective efficacy of sonnei. There were not enough cases of Shigella Flexneri 2A shigellosis to demonstrate to analyze protective efficacy against Shigella Flexneri. A very important data generated by this study were the levels of IgG antibodies against Shigella sonnei, and there was a very clear correlation, a nice correlation between the level of IgG anti-Shigella LPS, Sonia LPS antibodies, and the level of protection in the 3 age groups. There was a clear correlation between the level of antibodies and protection, or lack of protection. And these were important data, although actually there was a bit of frustration that the vaccine only protected children aged 3 to 4, but was not protective in younger children. Collectively, the data along the years from observational studies and clinical trials showed that serum IgG antibodies to Shigella OSP or Shigella O-specific polysaccharide are correlates of protection, and actually these antibodies actually fulfill the criteria that Stanley Plotkin proposed for a correlate of protection, and we have seen that they significantly were elicited by Shigella natural infection. They were associated with a reduced risk of disease under natural conditions of exposure. They were associated with protection induced by the candidate vaccine and efficacy studies. I haven't shown these data, but the reanalysis of the data, the 2 efficacy studies were which were the only studies carried out as a phase 3 study with the Shigella vaccines in the last 50 years, both of them in Israel. They actually yielded data that showed that we could actually identify a threshold level of protection with antibodies against Shigella sonnei, and we found out that these antibodies are also mechanistic. They are functional, and in terms of bactericidal activity, we found a very nice correlation between the levels of IgG anti-Shigella LPS antibodies and the serum bactericidal titers in the same sera following vaccination, before and following vaccination with a sonnei conjugate. So this was actually all related to the first generation of the vaccines. Good results, but not enough, because there was not enough protection in very young children and in infants, and this is not good even if we want to use a vaccine in Israel, for example, where we have countrywide epidemics every few years of Shigella sonnei in children. But of course, if we speak about developing countries where a vaccine is needed, in children under 5 where they die of shigellosis, so a second generation of conjugates has been developed in order to address this, to have better immunogenicity and better protection in young children. And one of these new representatives of this second generation of conjugates is a carbohydrate-based conjugate vaccine developed at the Institut Pasteur against Shigella flexneri 2A. This is the synthetic oligosaccharide of Shigella flexneri 2A linked to tetanus toxoid as a carrier protein. It is a pentadecamer of synthetic oligosaccharide conjugate, as I said, to tetanus toxoid, and the synthetic oligosaccharide mimics the O-specific polysaccharide component of Shigella flexneri 2A, and these are the 3 repeating units that of Shigella flexneri, which are actually represented by this synthetic oligosaccharide in this conjugate vaccine. The vaccine, as I said, was developed at Institut Pasteur by Laurence Moulard and Armel Falipon, and we carried out the phase 1 study here in Israel with this conjugate vaccine. We had a long time collaboration with Institut Pasteur in Shigella research and Shigella vaccine development, and we were those who actually ran the first-in-human, first-in-man phase 1 study with this conjugate, and that was in collaboration with the Tel Aviv Medical Center, and that was a safety and immunogenicity study. of this vaccine. And very briefly, we had the 64 young adult volunteers who were randomized to receive a low and a higher dose of the conjugate, the 2 microgram or 10 microgram of the conjugate, and in these cohorts they received the conjugate either with alum or without alum as an adjuvant, and there was a ratio of vaccine to placebo recipients 3:1. Volunteers received 3 IM injections on days 0, 28, and 56, and there was an immunological and safety follow-up after the volunteers. And we actually looked at the large battery of immunogenicity outcomes, much more that we've done previously, and we look at humoral immune response to the vaccine in terms of serum IgG, IgM antibodies, IgG subclasses, urinary antibody response, which is an IgA, secretory IgA. We showed in the past that these are good indicators of secretory IgA. And we looked at functional antibodies, serum bactericidal antibodies, and also to the response to carrier protein. And we also studied the B-cell response, both the antibody secreting cells and also the B-memory cell response. So the main findings of the phase 1 study of this new generation, second generation, this time of synthetic conjugates, was that vaccine was safe and immunogenic in naive adult volunteers. They were screened to get rid of those with pre-existing antibodies, and the vaccine was immunogenic in both the low and high dose of olisaccharide, but the stronger immunogenicity was obtained with a higher dose of 10 microgram dose, and they were functional, showing actually SBA, serum bactericidal activity, and avidity. And the alum adjuvant had positive impact when the vaccine was given at 2 microgram. And as I said, the vaccine also elicited a significant rise in the percent of specific B memory cells to Shigella flexneri 2 ALPS, suggesting priming for a sustained immune response. There was stronger immune response than natural infection when we compared the immune response of the vaccine. And just briefly to show that, for example, the IgG response, which is the main, I would say, immunological outcome to be assessed for this conjugate based on our previous data, showed an impressive response after the first dose of the vaccine. These are the vaccinees getting the 10 microgram dose. This was the rise as compared to pre-vaccination, 20-fold rise in titer without or with alum, the same, more or less the same immune response as compared to the pre-vaccination. Not too much added by the additional doses, but what is much important is that the immune response was much higher as pre-vaccination time, but the level of serum antibodies were so much higher than those in the placebo recipients, also showing that again, all what was gained in terms of the immune response, in terms of serum IgG antibodies to Shigella flexneri LPS in this case, was actually associated with vaccination. Nothing actually occurred following natural infection because the placebo recipients did not show any response. They were not exposed to Shigella flexneri during the follow-up. The vaccine also showed good serum bactericidal antibody response, and this is, again, the 10 microgram. This is without alum and with alum, and this actually documents a functional immune response with very high rate of volunteers, of responders, as compared again to no response in placebo recipients. And in terms of memory B cells, this is important to see that there was I would say a 10-fold rise or a 24-fold rise in the percent of IgG antibody secreting cells against the Flexneri 2A out of the total IgG antibody secreting cells following vaccination. This is the IgG memory cells as compared to pre-vaccination, as compared to placebo recipients without and with alum. Just to try to add more information on the immunogenicity of this vaccine, we studied the long-term immunological follow-up on these phase 1 study volunteers, and this study was led by Shiri Meron-Soudai and Valeria Sato. They are here in the audience. 2 and 3 years after receiving the last vaccine injections, the volunteers were approached to participate in an immunological follow-up. And what we found is that the GMT of IgG and IgA remained significantly higher as compared to pre-vaccination. The functionality of the specific IgG, specific induced antibodies was long-lasting as documented by the SBA and the VDT results. And interestingly, and this is an important, I would say, more generic finding, is that the B memory cells declined to baseline, okay, after 2 years, but however, their level at 3 months after vaccination were actually good predictors of the levels of all of the most important humoral parameters 2 years after vaccination. So although they went down, it was the only parameter which went down, but they were good predictors of what happened 2 and 3 years later. And this is just an example of the longevity of the serum IgG to IgG response. Again, this is 3 months after vaccination. There was a decline, of course, this is pre-vaccination, of course, in the level of the IgG 2 and 3 years after vaccination, but still almost 90% of the vaccinees had fourfold or higher rise, fourfold higher level of antibodies compared to pre-vaccination. There was a good durability, longevity of the serum IgG antibodies, and nothing happened among the placebo recipients, again showing that nothing is related to exposure to Shigella Flexneri 2A in this population. This was expected because these volunteers were in Tel Aviv area, not exposed to Shigella Flexneri 2A, which is much restricted to the south of the country. And this is just the last slide before conclusions, showing that this is the level, the count of the IgG B memory cells at 3 months post-vaccination. And this is the high count. And we can see that the serum IgG, serum IgA, and SBA were increased 2 years after vaccination, much higher in volunteers who showed this higher level of B memory cells 3 months after vaccination. Just to conclude that the correlates of protection, there identified thresholds that we found out and we developed along these studies and both observational and vaccine studies, and their reassessment in young, they are important as a reference, but their reassessment is needed in young children and infants in low and middle income countries. I'm speaking about the IgG levels against the polysaccharide. The data on the safety and immunogenicity of the new glycan-based Shigella conjugate vaccine are synthetic glycan-based conjugate are promising. A phase 2A study of the safety and immunogenicity of this vaccine is currently being conducted in infants and young children in Kenya. And the controlled human infection model study and 4 preliminary efficacy results has been just completed in the US, while our lab actually is running all the immunological parameters in view of our experience and the possibility to compare with the history of the other conjugates and, of course, with the phase 1 results of this conjugate. And tetravalent configuration of the glycan-based synthetic vaccine comprising Shigella soniae, flexneri 2A, 3, and 6, the most common Shigella serotypes worldwide, is under development. And I want to thank many people, but first of all, I want to thank to my group, to the members of my lab, and these are those who were involved in the last year studies, Anna Bialik, Shiri Meron-Sudai, Valeria Satos, Sophie Goren, Ariel Cohen, and Aravaz Raizis, and Shubham Mathur, and the other colleagues at Tel Aviv University, at the Chita Muhsen, and Tel Aviv and Schneider Medical Centers, Atzmon, Ashkenazi, and others, those who were the physicians responsible for recruiting the volunteers, and of course my colleagues and friends and collaborators for many years, Philippe Sansonetti, Armel Falipon, and Laurence Moulard, and Ravid Bassar and Tami Shohat from the Research Center for Disease Control. And just to acknowledge that these studies were in part supported by the European Union 7th Framework and the Bill and Melinda Gates Foundation. And thank you for your attention.
Thank you, Dani. I think we have time for one question. Yariv, speak up.
Dani, show a lot of data about the quantities and dynamics of the antibody and T cell. What about the quality? Because it's interesting. You have you know a lot about the toxoid response. We know a lot about LPS response and humoral response. But together and they act differently. I'm talking about subclasses, for example, of IgG that are responsible for effector function. So if it's tetanus toxoid can behave one way, LPS different way. So
yeah,
what do you know about that?
Okay, this is a good question, and we have answers for this because we studied the subclasses response, IgG1 and 2, both against the following natural infection and vaccination, and we have very interesting results actually showing that there is a difference in the relative importance and the ratio IgG1, IgG2 following a Shigella soniae conjugate and the flexneri conjugate. And this probably depends because they have the same actually carrier protein, but the OPS, the OS are different. So this is probably related, associated with the O-specific polysaccharide. And these are that's an important observation, and I didn't show the results of the phase 1 study. They are published, and we now look actually at the persistence of IgG1 and 2, their ratio, and there will be the results showing and analyzing their association with protection when we analyze the challenge study, what is called the SHIM study, which is carried out now in the States, and of course when we reach the phase of an efficacy study with this conjugate.